So this okay. Why I have chosen intervention nephrology as a full-time job? Uh, what happened actually? I joined here the institute. It's known as SKIMS, Seri Kashmir Institute of Medical Science, in 2019, 1819, as an assistant professor of nephrology. What happened there? As every nephrology faces the same thing, that you send the patient for you put the neckline and send the patient to the vascular surgeon, and he gives the time that we'll need it 2 months, 1 month, 3 months. For example, you are sending the patient in June, you are getting the number in the November. So that way there's a mortality, there's a huge mortality of the patients, young patients, between this period, that first 3 months, without proper or the proper access or the working access. It's very difficult. It's very difficult. Or the dysfunctional access, no treatment at the time, that angioplasty, you give the call the cardiologist. The last case will be the your nephrology case, and ultimately it's cancelled multiple times. You will face lot many problems, so that you are forced to do everything yourself. It's actually a it's a force, that it's a you have to do it for your patients. So somebody has to take initiative to become an intervention nephrologist and teach others, so that there is every hospital, every department has their own intervention nephrologist. There is a timely intervention for your dysfunctional fistulas, or there's a timely, for example, you got the patient today in OPD, you will see the patient will put a neckline or the permacath and meet the fistula on the same day. That should be, and the dialysis on the next day or something like that. So this was my aim for becoming an intervention nephrologist. Uh, I, s- um, I actually worked very hard for getting the fellowship from a lot many places. Ultimately, I got the opportunity to work with in a great prestigious institute of CMC Vellore, and ultimately I completed my fellowship there and came to and joined Apollo as an intervention nephrologist. But due to some family issues, some family problems, came back to Kashmir and joined the Khyber Medical Institute, where I have a dedicated cath lab and my own dedicated theater, so I can make the fistulas for 3 days in a week, and 1 day for the intervention, this cath lab. So I do almost all procedures, not all procedures, almost all procedures of intervention nephrology, and I am very much interested in teaching the young fellows or my colleagues. So I'm always open for them. I'm available for them, so anybody can come and get something from here. Thanks. So can I start, sir? Shall I start?
Yeah, just
Yep.
start, please.
Yeah. So today I have given the topic of ultrasonography to guide PD catheter placement. So I'll not introduce myself now. Uh, so uh, Peritoneal dialysis catheters are one of the most successful long-term transcutaneous access device ever used in medical science, and the catheter, if successfully placed, can provide successful dialysis for years. And point of care ultrasonography is an invaluable tool, not only to guide the percutaneous placement of the catheter, but also to confirm the appropriate location where to put the needle and diagnose the complication at the bedside and at the early stage. Now, before going to the ultrasound of the abdomen, we should know the anatomy of the abdomen. So anatomy of the anterior abdominal wall, or anatomy of the any part where you are going to do the ultrasound, is very utmost important. So I'm going just few slides for that. So this is the anterior abdominal wall. These are the muscles. These are the mediolateral muscles, internal oblique, external oblique, and the transversus abdominis. They join and form the aponeurosis, which covers the pair of muscle, which is known as rectus abdominis. The muscle of interest in PD insertion is this rectus abdominis and this linea alba. So it covers the anteriorly, it forms a sheath and covers the rectus abdominis muscle, and posteriorly it forms the sheath and covers the rectus abdominis muscle. and joins in between them and forms the linea alba. On the other side, it's the same thing. So when we get a there's a transverse cut, longitudinal cut. So we'll get this is the skin, this is the umbilicus, and below the skin there's a subcutaneous tissue. Then the anterior or the external rectus sheath, then the rectus muscle, then behind the rectus muscle, posterior rectus sheath. In between them there's a vessel. So if we go through this, put the needle through this, will hit the artery that's known as inferior epigastric artery, which is important artery. If we hit this, we'll form a hematoma. So to avoid this complication, the ultrasonography is very important in PD insertion. So this is the posterior rectus sheath, then the extraperitoneal fat, and this line is the peritoneum. So this line we have to have to see in the ultrasonography to puncture this, and at the safest site. So this is the vessel, this is the femoral artery, this is the inferior epigastric artery, the branch of actually is the external iliac artery. So external iliac arteries give the inferior epigastric artery, which runs medially in the abdominal wall, just behind the rectus abdominis. So we are putting generally 1 to 2 centimeter below the umbilicus or lateral to the umbilicus. So this is the site where it runs. So it should be initially taken into the consideration that the inferior epigastric artery is running through this site. So I have to go away from 1 centimeter here or 1 centimeter here, medial or lateral to the artery. So this again the same thing, that the 3 muscle, they form the aponeurosis, covers the rectus abdominis muscle, form the linea alba, and same thing, and there's the vessels behind it, and then there's a peritoneum. It's a bright thing on ultrasonography. The same thing. Now the screening and pre-operative evaluation. So for sonographic assessment of the PD catheter, we choose linear or high frequency probe, because it adequately visualize the superficial structure. And in obese patients, obviously we choose we have to look for the deeper deeper because the fat is more. So we use the curvilinear probe. So the first modification of the pure fluoroscopic catheter placement method using ultrasonography guidance were published in 2007. And the use of ultrasonography appears safer when compared to the fluoroscopic guided blind needle puncture. Because in fluoroscopic puncture, we cannot see the artery. We may see the bowels moving, but we cannot see the artery, the inferior epigastric artery. And color flow it helps to avoid an accidental injury of the vessel during the needle. The technique has several other advantages over the traditional methods. It does not need any bowel preparation or not much bowel preparation. The procedure can be performed as an outpatient ambulatory procedure, which does not require pre-operative clearance, and only minimal laboratory data is required. The patient receives only conscious sedation or no sedation at all. Most patients only have a small amount of IV pain medications during the procedure or the post-procedure, and some you may avoid it also. Patients usually can resume normal intake by mouth immediately after procedure, because there's a only needle prick or the catheter insertion. There is not much handling of the peritoneum. So this approach helps choose alternate peritoneal access location in the case of bowel adhesions located at the paraumbilical region. If there is adhesions, we can go away from those. We can see the movement of the bowel and all these things, and then make the plan of insertion of the needle. So ultrasound guidance for peritoneal dialysis placement. So what structures we have to visualize? So in real-time ultrasonography, we have to visualize, we see the needle going in through these structures. First the subcutaneous tissue, then the rectus abdominis. We feel the anterior sheath resistance, then the muscle, then the posterior sheath, and then the peritoneum. And when you go through the peritoneum, there may be some pain. So subcutaneous tissue is the most superficial. It looks hypoechoic band. in the ultrasonography, and then rectus abdominis muscle is in deeper hypoechoic band of various widths, showing linear high specular echoes, and then the peritoneum is seen as an echogenic line, just deep in relation to the rectus muscle, abdominis muscle fibers. So we can see in the ultrasound, this is the picture. This is the subcutaneous fat with some fibrous tissue in between. Otherwise, it's hypoechoic. Then the interior or the external rectus sheath. Then the rectus muscle. We can see the vessel here. So we have to avoid to go into the peritoneum. We have to choose this side or this side. And then the internal rectus sheath or posterior rectus sheath. Then the peritoneum. This the bright line is the peritoneum. We can see in the broad view, this is the broad view, this is the peritoneum, and all the three muscles form the aponeurosis, covers the rectus sheath, forms the linea alba. This is the video. Today I have taken this video. The subject is my assistant. So I will show you first. We have to choose, this is the Logic P9 machine. I have choose first the linear probe on the abdominal preset mode, then put the probe on the below the this epigastrium, then see the structure. These are the structures we can see. This is the subcutaneous tissue, the hypoechoic, then the septations of the this fibrous tissue. This bright line is the interior or the external rectus sheath formed by the aponeurosis of the muscles of the abdomen. Then they cover this the rectus muscle. This is the posterior sheath, and this bright line is the peritoneum, and this is the extraperitoneal fat. You can see this extraperitoneal fat as in hypoechoic this, and this is the peritoneum. It's the bright thing, and this can be seen as this is the bowel with the stools inside, fecal matter inside. So I'm going down. I'm going first to the side of the abdomen. So you can see this the rectus muscle. Rectus muscle sheath is anterior and posterior, which is formed by the aponeurosis of the other muscles. This is the aponeurosis, which is joined, which is known as linea semilunaris. So these are the muscles. This is the external oblique, this is the internal oblique, and this is the transverse muscle. And below it is the peritoneum and the bowel, you can see. So when I go down, this is the umbilicus, and below umbilicus, now you can see below umbilicus again the same thing. This subcutaneous tissue. This is the anterior and the posterior rectus sheath. This is the rectus muscle. This is the linea alba. Some goes to this. This is the peritoneum. This is the peritoneal line. So we can go through this below the umbilicus. Many people choose umbilicus linea alba for the puncture. This because you avoid this inferior epigastric artery in this. When you go blind, you go through this. And then go down, you have to see always a bladder, full bladder. You have to avoid that in the NG puncture. So you have to ask the patient to avoid. These are the bowel. You can see the bowel. And this is the bright line. Bright line is this bright line. It's a very bright line. I will just pause it. This the bright line. This bright line is the peritoneum. You can go this way. You can go this way. And this is the bowel. You can see the bowel. So you can go this way. This you have to puncture from here. You go here and put the needle here. And then under fluoroscopy, give the dye and the web-like structure. And when you see the web-like structure, and then put the guide wire and the sheath, ultimately the other things. So below it, I'm going down. This is the bladder. This is the bladder. I'm seeing in the linear with the linear probe. So below there is no linea alba. There's the joining of the muscles. These two muscles join. So again, the scene now color Doppler. On the color Doppler, you have to see this is the vessel. This is the inferior. Let it settle. This is the inferior epigastric artery. This then, and there's one more branch. So you have to avoid this place. You have to go through this place or this place, whatever is the feasible that time. So I've taken the this also, there's a good flow in it. Peak systolic velocity was good. So this is the vessel. And now I have chosen because in obese patients, sometimes you have to go for the curvilinear probe. This again same thing. This is the rectus muscle, Then the in between them is the linea alba. Then the rectus muscle. This is the umbilicus. Below it, this is the place of best place for the just lateral or below the umbilicus. So this is the linear, this is curvilinear probe. See, now going down, you can see the air shadows, and this is the urinary bladder. This ends my presentation. Thanks everybody for watching. Thanks.
Thank you, Aadhil. I think we'll